Hello, this is a Health and Politics podcast. Prevention is the new cure.
With former ministers Steve Brine and myself, James Bethell.
Hello, James. The sun is shining.
I know, it's straight in my face, and I'm sorry the video is going to be a bit skewy from this, but boy, oh boy, it makes me happy. I've got such Scottish genes. The smallest amount of sun at this time of year just gets the vitamin D fizzing away. I come out of hibernation. It's an incredible physiological reaction.
No, it's extraordinary, isn't it? Because the world news is so glum, and yet there's blue sky here in Hampshire this morning. I was outside yesterday afternoon having a cup of tea, giving the dog a brush, and I almost thought about mowing the lawn.
Oh
Do you know what I mean?
Yeah, that's crazy. It's sort of too early. Don't mow yet.
I know. Do you know what? I went to watch a rugby match yesterday afternoon, James, at my son's school, and I'm not a rugby player, as anybody who knows my shoulders would tell you. But I went to watch it, and they're sort of under 15 rugby side, and I really enjoyed it. I really enjoyed it. You like rugby, don't you?
Well, it is a phenomenal thing. Under 15-year-olds these days play at an incredibly high standard. You know, when I used to play rugby at under 15, it was all very messy and no one ever caught the ball. These days, they're so well drilled, really well trained. The rules have become more understandable. No, I totally enjoy it. I also greatly enjoy lacrosse. My daughter plays lacrosse. Boy, oh boy, that's a tough ding-dong game. I really look forward to that one.
Is it brutal? Yeah, I was watching them because it was 27 at half time and it finished 2012 and they defended so well and they're now in the final of some school's cup. So yeah, no, I really enjoyed watching it and it was sunny. And then last night, very interesting actually, I saw the Lady Chief Justice. Now, the office of Chief Justice has been going since the late 13th century. And how many women do you think have held that role during that time, James?
Well, I could do it on one hand for sure, even on one finger, I suspect.
and she is that one. So yeah, the Honourable Baroness Carr, she came and she gave the lecture. I don't know if I've ever mentioned this before, but so my father-in-law was Lord Toulson, Roger Toulson, who died quite prematurely back in 2017. But he was a High Court Justice and he ran the Law Commission, and then he was at the Supreme Court in the very last job that he had. And when he passed away, he gave his books to University of Surrey, where there's now the Toulson Law Library. And the law school there have a lecture every year, the Toulson Law Lecture. And we've had some really interesting people give it over the years since it started in 2019. And the Lady Chief Justice came and did the lecture last night. So we went along, listened to her talking about common law, which was very, very interesting. And then we had supper with her. So yeah, it was great.
Fantastic. Oh, well, that's very lovely. I had a very inspiring breakfast yesterday with Melanie Iverson, who is heading up HDRS. So that's our NHS initiative chaired by Nicola Blackwood to try to sort out data, particularly for research. It's not all clinical data, but it's the bits of population data that researchers need to understand the patterns of health in our society. It's been a really knotty problem. I won't bore everyone right now, but in COVID, we did a lot of progress in this kind of area, and the initiative has kind of fallen back. HDRS is hopefully going to reboot that. Melanie's come from the private sector. She's clearly very heavyweight, very thoughtful, plain speaking like people from the private sector can be, which is so refreshing when you put them into a public. And this area is incredibly important for the UK. Whenever you travel the world, people say, oh, you're so lucky in the UK. You just got one NHS and one big pool of data to draw upon.
Yeah, really.
And you think to yourself, yeah, kind of, sort of. Not quite like that. More like a sort of series of puddles, sort of. But you don't really say that. She's going to sort out the puddle problem. And I've got real confidence that she's going to do it. She was really impressive. I'm going to try and persuade her to come on the show.
Oh, that'd be really interesting. Yeah, Nicola Blackwood chairs that now because she's in the Lords with you and she was in the Commons with me. So she's a good thing, Nicola. Now, just before we get on, James, let me ask you this question. Strictly in Parliament.
I'm in an awkward spot on this one. You know, I try to be one of life's positive people, but I just can't get Strictly. I did 10 years at the Ministry of Sound. Maybe I'm being a bit of a dance snob here. It's a weakness. I'm not proud of it. But yes, we had MPs led by the Speaker dancing around Portcullis House. It was kind of, I suppose it was fun, but it's unusually for me. It did make me feel a bit grouchy. What did you think? You're probably a huge Saturday night fan.
I do. I mean, I have a teenage daughter, so it's kind of compulsive watching, and I do actually really enjoy it. I have a sort of secret man crush on Craig Revel Horwood, but Angela Rippon was in there yesterday in Portcullis House, and she was dancing. You're right, with the Speaker and loads of MPs, and it's gone down really, really badly because we are currently in a very grave situation. There are British citizens that are under threat of mortar bombs in the Middle East, and MPs are dancing in Portcullis House in the same week that a pay rise has been announced. That's what it says on social media, which of course must be true.
Yeah, I know.
I think they were actually trying. He says, as a co-host of a health and politics podcast, they were actually trying to promote the benefits of health and activity and exercise and movement. That was the whole point. And sometimes maybe they get the choreography wrong, no pun intended. But hey, bit of fun, and it was sunny.
No, well, the aspiration is a good one. I do. They say, yeah, it's brilliant. We need to do more of that. There's a lot of drinking in Parliament. I have periodically suggested that we did dry January in Parliament, and someone took me to one side and said, "James, if you want any political future whatsoever, I would really shut up."
You know what, though? I was in there for the best part of 15 years, and I can honestly say to you that I could count on one hand the number of alcoholic drinks I had. I used to, because I know that makes me terribly dull, but I saw the House of Commons as my workplace. And I wouldn't drink in my current workplace since I left the House of Commons. So you can go to lunchtime receptions and there'll be wine. You can go to afternoon receptions and there'll be wine. You can then have a dinner in the evening and there'll be wine or beer. And I just thought, this could so easily get out of control. And so I never did it. But I know plenty of people do, and I don't judge them for it. But the days have changed from the late night boozing because the Commons doesn't sit late night. But there it is. Listen, thanks for finding this podcast. This is called Prevention is the New Cure. We talk health and politics. We were both ministers. James is still a member of the House of Lords, and we talk politics. We talk health policy. I think we try to give insight, James, don't we, from our experience on how policy making actually works in government. And you can subscribe to us now, wherever you get your podcasts, or on YouTube, and even leave us a review if you can, because that really helps. You probably saw Ashley Dalton step down as the Public Health Minister, which is my old job at the Department of Health. And it's sad to see. She sort of stepped down to focus on her constituency work because she's undergoing further cancer treatment. She has stage 3 breast cancer, does Ashley. So sorry to see her step down because she's a good thing. And she put the cancer plan out last month, of course.
She's a very good thing, and our thoughts and prayers are with her. She's been replaced by Sharon Hodgson, who is also a good thing. And Sharon is a proper Gateshead MP, so someone who lives with the consequences of our public health deficit in the UK, is extremely energetic. She's a Miliband Labour, so sort of from the sort of core of the current Labour Party, and quite high profile. She's been around since 2004, and I'm pleased to see someone with heft and recognisability in Parliament in this job, because maybe they'll be able to get some things done. So let's try and get her on the show as well.
Yeah, I have already asked her. So I know Sharon really well. We chaired the all-party breast cancer group together in my first Parliament. So that's how I know her. And she was Keir Starmer's PPS, actually, until relatively recently. So, yeah, she'll be a good thing. I think I said to her when she was appointed earlier in the week, you'll see how great it is, to be the Public Health Minister, which I saw you tweeted is the best job in government. I agree. But also how great it is to be able to turn a passion into actually being able to do something.
Yep.
Having run a cancer APPG for as many years as she has, and she's been involved in the ovarian cancer group, etc., etc. She's going to find it great, and I hope she'll come on the show and talk about us. So consider this an open invitation, Sharon. Right. Shall we look at some of the comments that have been coming in since last week, James, on LinkedIn? You can join the conversation on there, by the way, or on X, or on the YouTube videos, as I said. Quite a few comments, just a few to read out. John first name only, complete underinvestment in research to find a cure for tinnitus. Tinnitus costs the NHS about £750 million a year and affects 1 in 7 people. Wow, I didn't know that.
Yeah.
Suicide ideation is double that of the general population, yet receives 40 times less funding than depression. Well, we've never talked about tinnitus on the podcast, have we?
Well, we haven't, but it is huge. I had an uncle who got it from a trip to Tibet when he came out of a car. Really disabling. John Hayes MP, the very well known former frontbencher in the Tory party, has it very badly. He speaks so movingly about the daily struggle he has with his mental health, trying to manage this wearying, constant, distracting affair. It's in the bucket of one of those things we just don't know much about and don't seem able to fix. But my goodness, Steve, we must be nearer some kind of progress on this.
Yeah, it must literally drive you. Yeah, John's a good man. Love to talk to him about it. I don't think I've ever talked to him about that when I was in the Commons with him for
I
15
nearly cried
years.
when he was describing it. It was one of those touching moments. Yeah.
Yeah, another one, Duncan. 4th of March, chaps, marks World Obesity Day yesterday. Is Big Pharma and Big Food invested in an oversized population? Discuss. Love the podcast, fellas. Thumbs up emoji. I think we are going to discuss that in a bit today, aren't we?
We are. I mean, Duncan's absolutely got a point. And the irony of junk food companies investing in pharma companies that are making big returns on GLP-1s is just too awful. So, yes, BMJ editorial addresses this point, raises some really big issues. So unusually, Steve, I think we're going to take a bit of a deep dive on that and try and nut out some of the complex issues.
Now, last week we had Charlotte Resham, lovely Charlotte from the Tony Blair Institute was our guest last week. We were discussing interventions, using GLP-1s, asking why people are waiting so long to get sick before we help them. We're going to come on again to that. Carolyn commented, we know that early intervention works, but it is easy to justify funding activity than funding something that doesn't happen because we prevented it. Good point.
Carolyn is right, although we do that with cars and building sites. I mean, we do have a safety by design framework for other industries. It's just things like drink and food that we struggle with. Helen said, good prevention and care of higher weight people is not weight management. In fact, weight surveillance and the first line treatment ethos surrounding it is causing more harm than good. I think here that Helen does have a point. The way that the conversation around some of these treatments is going is not to think of them as addressing obesity, although obesity is a disease, thinking of them more as addressing cardiovascular, musculoskeletal, and cancer risk. If you think of it through that lens of trying to reduce weight in order to battle other diseases, I think that is a healthier way of thinking about it. And it takes some of the shaming and the issues around food issues out of the mix. So, yeah, Helen, I think you've got a good one there.
Yeah, final one, Vicky. The problem is that most people don't want to spend money, time, or do anything hard or unpleasant on the chances of it stopping something abstract. Humans do not work that way. Vicky, you should work in the Treasury. That's
very good.
But she was responding to the conversation we had with Charlotte about prevention, and a lot of policymakers think like this, don't they?
Yes, I thought she meant the public, and I was going to be saying actually the public's more. You should give the public more credit than that, but policymakers maybe not. Yeah, there is this very bad thing in the NHS at the moment that everyone is chasing in-year savings. Oh my God, that phrase, in-year savings, particularly in health, when your health is really a risk management exercise anyway. It's just so heartbreaking, Steve. We do need to be looking a bit further on the far horizons.
Yes, and we do need to crack on. So this week on Prevention is the New Cure, we're going to start, James, with the bombshell stat that made headlines in the last week. NHS spending has doubled to £200 billion in 17 years. And James, you told the Telegraph it's had no impact on the nation's health. I wish you'd say what you think. So we're going to start with that. And then where we're going to go.
Then we're going to touch briefly again, because we discussed it last week with Charlotte Revsom, on whether the new GP contract paying doctors to prescribe weight loss jabs is real prevention or, according to the BMJ, simply pharma capture.
Interesting. After that, we crossed the Atlantic because RFK Jr., Robert F. Kennedy Jr., has quietly pivoted the MAHA movement, which stands for Make America Healthy Again, from vaccines to food. And 18 US states are about to ban candy, otherwise known as sweeties, on food stamps. So what does that mean for US health policy? We will discuss.
And we finish with a toast to 500,000 biobank volunteers whose GP records just got unlocked, and 20 bone scanners that could save the NHS billions.
Brilliant. Look, thanks for listening to the show. As we do that, we'd be delighted if you want to subscribe. You get brand new episodes as they drop each Thursday. You can WhatsApp us, actually. Ideally, leave a voice note and we'll play it on a future episode. The number for our WhatsApp is 0333 404 6507. 100 billion to 200 billion. That's what Britain now spends on the NHS every year, James. Double what it was 17 years ago. Now, you said in the Telegraph last week that doubling it has had no impact on the nation's health. You were the lead story on the Telegraph last Thursday, which I'm sure has caused an awful lot of traffic your way since you said that. So I think we really just need to discuss this, James. We need to unpack this, and I need to challenge you a bit on it. So this is your piece, this is your argument. You told the Telegraph this, and then I suspect you've done other media since, alongside Jonathan Van Tam, that the state should behave more like a private insurer, intervene early, keep you healthy, reduce claims. You also said that the health secretary had told you he had, quote, no money for prevention. Make the case, James, that Britain will be bust before I die unless we fundamentally reduce spending or redirect spending.
Well, Steve, I don't have to make that hard a case, to be honest, because you just have to look at the healthy longevity scores and see how for the whole country, the period that we spend in sickness towards the end of our life is increasing. And in particular for the bottom half of the socioeconomic slice of the country, it's increasing quite a lot. And in fact, even longevity, the amount of time that people spend on Earth, is reducing for those people. So, and then we have this massive dropout from the workforce of millions of people on sickness benefit, unable to contribute to the economy, to their community, and often creating a burden for other carers. I mean, there's no other way of putting about it. So something is clearly broke. So we've had this political discourse that we need more doctors, more money, that will somehow fix the problem. But before we, really rely on that, we should just be honest with ourselves that we've doubled the budget, but the results have got worse. Now, there are mitigating factors. The population has increased. Some diseases are more are multimodal and are more complex. We do have now more expensive treatment. So, but still, it has doubled. It's not like it's gone up a little bit, and disease has gone up a lot. So something is clearly broken here. And the reaction I got to the story, which was huge, was universally positive. No one said to me, that's outrageous, your stats are wrong, you don't have confidence in the NHS, this is just sledging our health system. Everyone's in this space at the moment. And I remember so well Paul Johnson from the IFS, who's a sort of dragon slayer and person who speaks truth, put this in his book about 5 years ago. And when I first read it, I was horrified and thought that he was just a nihilist and depressing and needed to sort of understand a bit better the opportunities from better health. I now come round to it, and I think he's got a point. And we need to have this honest discussion about whether just piling more money, more nurses, more doctors, more hospitals into the system is actually going to yield any dividends at all.
I suppose the first point to make here is these big figures that we're giving, they're England. This is not UK. These are England figures.
But it's worse in Scotland and Wales.
True. But then so is deprivation and inequality. The Telegraph story seemed to suggest that we were talking about doubling in a decade. And I've certainly, whether that is exactly what it said, but I've heard that repeated since by commentators.
Yeah, it's not.
It's not a decade. It's 17 years. So
17 years, yeah.
It was 100 billion from about the mid 2000s, early 2010s to 200 billion today. Also, the people also have to break it down as well. So what we in ministerial departmental talk describe as the RDEL, so the resource department expenditure limits, that's gone from about 125 billion to 158 billion. So that's a 26% increase, not a 100% increase. The IFS work shows that spending on health as a share of national income has more than doubled since the NHS began in the 50s. And you mentioned IFS earlier, but Wes Streeting is very often on record as saying we have to avoid being in a situation where we have a health service with a country attached to it. But let's just remember the size of our country and our GDP that we are spending. I mean, it's absolutely minuscule, really, in terms of GDP. If you compare it to other comparable countries. So, for £100 of GDP, we spend about £10 on health in the UK. So we're now on UK figures. France 11, Germany 11, US 17. So health dominates UK spending in a way that it didn't. It was overtaken in the past. We spent more on defense, we spent more on education. It's now flipped. We spend more on health and then defense and then education. But the counter argument to what you're saying is that a lot of that, of course, has been that doubling, has been inflation, it's been wage rises, as you say, the population has grown. And I just wonder, are we saying that the country is not under-doctored? Because if you listen to many of the organizations that represent doctors, no, they would say that, wouldn't they? But many of the think tanks who work in this space as well, they would say that this country is greatly under-doctored compared to many, many other industrialized nations. And you certainly feel that, and my constituents, when I was in the House, felt that when they're at the front door of the NHS. Do you accept that?
I hear it. I don't accept it. So I think that the challenges that we had in the past could be answered by doctors and hospitals. So the great revolution we had around, for instance, cardiovascular, putting in stents, heart surgery, brilliant, amazing that we've been able to do that. And cutting out cancers, again, amazing that we could save people's lives and give them extra years. But the chronic disease explosion we have today and the mental health disease explosion we have today cannot be solved by simply doubling, trebling, quadrupling the number of doctors. Why? Because the treatments you need are not necessarily administered by surgeons or GPs. And also, there just aren't any surgeons or GPs anywhere in the world for us to recruit. There is a capped and limited supply of these people. So we have to look elsewhere. So this constant refrain, that I call it the more doctors mindset, it is addressing a world that delivered fantastically for the country, and it's meant that our deaths from cardiovascular and cancer have gone down a huge amount. But that's not the problems we have today. And the 40 million people who are going to be carrying more than 2 chronic diseases in 2040, they're not going to be helped by meeting more surgeons and more doctors. So the reason why I raised it is that there is something wrong with the model, not the workforce. The model is that we have this environment in Britain that it's very difficult to lead a healthy life. I mean, strictly dancing in Portcullis House only gets you so far. For most working people, their day-to-day life does not contain the kind of activity and wholesomeness and good food that you need. In fact, it's depressing, tricky, full of junk food, full of all sorts of societal pressures. And the health service that we're putting together is not supporting them to try to find a route out of that. So we need to have a conversation that is much more about the determinants of health. And we need to have a health system that has probably a workforce that has slightly less emphasis on the highly specialized, high-end surgical doctor end of things, but covers more ground for more people on supporting them with their chronic diseases.
So then finally on this, let's consider where the public are in this. So I think when you come to budgets and the government put more taxes to, quotes, fund the NHS, which a Labour Chancellor is always going to do, it is a guaranteed clap, wave of the order paper. But is there a point where the public say, up with this we will not put, because we're not seeing the improvement of the outcomes? So current UK GDP 2.6 to 2.8 trillion pounds a year. 1% of GDP is about 27 billion pounds. So health's at about 10% of GDP at the moment. Defence, just to carry on that comparison, is about 2% of GDP at the moment. Obviously, government have plans to raise it. Where do you think the public are on this, though? Because what politician, exam question, outside of reform, even reform, will go to the electorate at the next election saying what the NHS needs is structural mindset reform, working with the public on upstream prevention, not more money. It certainly isn't going to be a government of the left, Labour, that is moving even further to the left as a result of the Denton and Gorton by-election. And I don't think, and I may be wrong, I don't think that our old party is going to have the courage to go there either. And the Liberal Democrats certainly aren't. The Greens definitely aren't. So is anybody actually going to go there in realpolitik?
Yes, they are massively. And today's crop of politicians are completely out of touch, in my view. You are right, Steve, that there will be more money for the NHS. That's a sort of historical inevitability. I can defend that another time. But which NHS? Are we talking about your version of the NHS, which is basically hospitals, because that is where 80% of the money goes at the moment? And by the way, the public hate going to hospitals. Given the chance, they'll never, ever go to a hospital again. This is something that, our NHS colleagues need to be reminded of sometimes. These huge, big supermarket hospitals out of town, highly contagious, awkward to get to, massive parking fees, long waits, hierarchical. I mean, honestly, the public hate them, really, unless you've got a really acute problem, and would avoid them if possible. And by the way, are irrelevant for most things that people go to hospital for giving blood, for having a scan. I mean, all of that can be done somewhere else. So yes to more money, no to more money just for hospitals. What the public really want is support for the things that they are struggling with day to day. And those are often in the community and often nearer home. And they're often relatively low level. It's about titrating their existing medications. It's about getting an update on from diagnostics. It's from bits of support that can be often done by a health manager or a physio even, or someone who has simple, relatively straightforward skills, not necessarily a 10-year GMC qualification and complex collaboration management training. So I think that the shape of the NHS is just all out of touch. And the proof point on this is that you get the feeling that the Treasury have given up on how the money has actually been spent because they don't think it makes any difference. So they don't care whether you spend it on new MRI scanners or whether you spend it on community nurses. They think it's just a sunk cost, like spending money on the British Council or on heritage. And that is a sure sign that the decision makers have given up on the model and that we need to present them with a better choice.
Yeah, I keep saying find me on this because there's so much to discuss on this. But I mentioned Ardell earlier, which is obviously the resource, the sort of day-to-day spend. But then you've also got what we ministers call the CDEL, so the Capital Departmental Expenditure Limit. So that has doubled over 10 years. So gone from about £5 billion a year in 14-15 to £12.5 billion a year in 24-25. But there's important caveats to this, James. So the CDEL figures are the annual planned budgets to spend on capital, but they're not what's actually spent. Capital budgets are still small, about 6% of the NHS budget. But of course, the last election that the Conservatives won, Boris Johnson went to the country promising, quotes, 40 new hospitals, close quotes. That was completely against the drift of where everybody in health expects us to be. It's completely obviously against the drift of hospital community, which the current government does. So therefore, the inevitable question I've got to ask you is, have the government? No. Should the government? Don't know. Ditch this new hospital building program? Because clearly that's not what we need to be spending our money on, is it?
Well, I'll put my hand up for some culpability here. I was definitely on the road selling the 40 hospitals promise. And electorally, it worked because we targeted communities that were desperately worried about the state of their hospital. Yeah, we need to back out of that hugely. It has really, Steve, been quietly dropped. most of the new build hospitals are no longer on the programme at all. Most of what's in the programme is really refurbishment. And the sums of money involved have come down tremendously. But yes, I agree. I would like to see a Secretary of State look down the barrel of the camera and say, we need a pivot. I often use this example. At the end of the Cold War, we took the entire British Army out of the Rhine, out of Germany, and moved it back to the UK. And we focused, instead of spending money on tanks, we went to special forces. It was very painful for the army. They had to get rid of regiments that they loved, and they fought it very, very much. We need that kind of seismic change in health.
We do, but put yourself in the shoes of Luke Murphy, who is the Labour MP, the new Labour MP for Basingstoke, who beat Maria Miller, colleague of mine. Now, Basingstoke is part of the same trust that my former constituency Winchester's in. It was promised a new hospital that was going to be in Dummer between Winchester and Basingstoke. If you're Mr. Murphy, sitting on a majority of 6,484, and you've promised your constituents in Basingstoke and the villages that they're going to get a new hospital from this new government that invests in the broken NHS, very hard for Luke Murphy to back out of this. Very hard for a health secretary who's got his eye on the prize and votes of Labour backbenchers to back out of this. So then again, politics comes into play, doesn't it?
Well, it does. And we need to give Luke Murphy a new lexicon, a new political playbook that he can talk about the investment in health in his community that does not involve the word hospital and doesn't involve spending several £100 million doing it. Somehow we need to let him talk about vaccines and school food initiatives and things that sound not very sexy today, but need to be converted into meaningful political delivery. Because I promise you, Steve, promising hospitals is not necessarily something that the public... I mean, I agree with you that that's the only way that politicians currently know how to communicate to the public about health. They're stuck with a sort of very old-fashioned, not very good playbook. We need to modernize the political playbook. And that is an absolute key building block to the pivot to prevention.
Well, Mr. Murphy, if you want to come on and talk about your new lexicon, then you're welcome to do so. Something that is sexy are these weight loss jabs. We're going to come back in just a moment and talk about them. Weight jabs won't fix obesity. Now, we're not going to talk about this huge length because obviously we touched on it last week, but the new GP contract, as we said, is about paying doctors to prescribe weight loss jabs on the NHS, James. This is the first time that obesity drugs have been backed into the core incentive structure of primary care, which is what the GP contract's all about. And you want to talk about a BMJ editorial, which I thought was really interesting. You spotted it.
I read the BMJ not because I agree with it, but quite often I don't agree with it and it gets me going. This one, I thought they really did have a point. I have been really worried that we're just going to medicalize obesity and give up on any effort to try to improve the environment in which people live. I think that would be a real mistake. I'm a total kitchen sink advocate. We have to throw literally all the tools we have at these kinds of problems. We have to get people moving more, like on Strictly. We have to improve the food environment, and we have to support people with the best treatments possible. What's really interesting, so BMJ have tossed quite a useful log on the fire, I think, there. I think one of the two things that are really interesting for me is just where GPs are on all of this. They're not prescribing the GLP-1s in any great numbers. That's really the private market. Private market is probably about 3.5 million at the moment. NHS GPs, 40,000, 50,000, something like that. It's a tiny number. Now, there are restrictions in the medicine procedures about what they can prescribe. So I'm not. It's not entirely their decision, but they're not clamoring for it either.
As well, yeah.
And secondly, I've got to be honest. They are not campaigning for upstream reform. When I go on my marches against junk food, when I'm in long meetings campaigning with the Obesity Health Alliance and with Jamie Oliver and Henry Dimbleby, there's never many medics in the room. They are not collectively leaning in to fight this. So are they campaigning for access for jabs? Are they campaigning against upstream junk food? They're just not really present in this conversation at all. And I think that's just a real shame because their opinion and their voice is really important. And the assumption you can make is that they just don't think people will change and that talking to them about their weight is pointless, and treating the outcomes of their own behaviors and decisions is what we're left doing. And I just find that nihilistic. It's a shame. And by the way, will also bankrupt the country.
Yeah, well, we've just been speaking about commercial determinants of health, haven't we? So Novo Nordisk and Lilly, who were in front of the Health Select Committee last week, are making billions from GLP-1s. Now, we've just been arguing that NHS spending is all about inputs rather than outcomes, and they haven't shifted over the years. But isn't paying GPs to prescribe Monjuro exactly the same mistake? We're spending more money on medical interventions when the food environment that creates the obesity is not untouched, but certainly undisrupted, to use Jim Mackey's phrase.
Look, yes and no. Listen, by the time your BMI is 29, 30, your body and the way in which you process food physically and you're neurologically changed. And getting back down to a healthy weight is unbelievably difficult. If your BMI is over 30, when you're in your mid-20s, the chances of you dying with a BMI under 30 are tiny, like less than 1%. So we have to recognize that this is our Neanderthal bodies and brains are just not good at coping with the 21st century. And I rejoice in the fact that we now have new tools to help people support that. But if someone has been on a course of treatment, if they go straight back to the same environment that got them in trouble in the first place without any changes at all, well, of course they're going to struggle to keep off the weight. So yes, we have to change the environment. We really do.
Here's a suggestion. Yeah, we say that Novo and Lilly are making billions on this, and they are. The share price, Lilly share price is in a fantastic place, actually outstripping Novo now. What if they were to, as a social responsibility, fund community weight management programs alongside that prescribing? Wouldn't that be good business? And wouldn't that then be good for society to prove that they want to be part of the weight management discussion and keeping the weight off? Actually, then to help to put money into community weight management programs.
Yeah, well, that does happen. So the drug companies work with their suppliers and their partners to create wraparound services that balance nutritional support, psychological support, activity to complement the drugs. And they also pair their drugs with other people's drugs, oncological drugs, cardiovascular drugs, in order to create the kinds of pairings that address disease specifically, not just sort of ambient weight. But I think we have to be realistic. The people who are good in laboratories with long molecules and getting safe, effective drugs through regulators are not the same people who should be or can be in charge of the behavioral science of engagement and adherence and psychological support. They're just, bluntly, the nerds in the labs should not be allowed near the patient front line. And they're just not good at it. And when they've tried to do it in the past, it hasn't worked out well. So we need a partnership. The way in which it's procured by the NHS is very important. I should declare as a conflict of interest thing, Steve, that I am an advisor to Oviva, which is one of these companies. I happen to think it's a very good one that is providing the full package into the NHS. And those platform providers, I think, do play a really important role.
Yeah. Now, someone who wants to move away from pharma interventions to something else is RFK Jr., who is leading the Make America Healthy Again push in the Trump administration.
Can I just ask you first, what's your emotional response to RFK? How do you, when he goes up with his funny voice and talking about kooky things, how do you react?
Well, I personally like to see disruptors. So I'm very happy when I hear somebody who I feel is not accepting just the sort of status quo. If I'm sitting with Mrs. Brine, I'm more circumspect because anything that is mentioned around the Trump administration gets a very, very bad hearing. So I have to be much more careful. But I like disruptors. I find him very hard to listen to. Just because, as you know, he struggles with his voice. But the reason that we wanted to talk about this is because, as we said at the top of the show, 18 states in the US are about to block food stamp purchases of sweets, candy as they call them, and sugary drinks. It's pretty much the largest coordinated state level nutritional intervention in American history. And the man behind it is the guy who told parents the vaccines cause autism, Robert F.
Yep.
Kennedy Jr. You spotted this story, James. I think it's really interesting. And just for people who enjoy our podcast, we do want to lean more into the Maha conversation. Maybe there's a spin-off there somewhere. Who knows? Watch this space. But I think it's a really interesting story that doesn't get a lot of coverage over here. But people are interested. Any Googling of Maha this week and Robert F. Kennedy Jr., and you will see this story everywhere stateside.
Yeah. Steve, it's huge in America. I have a simple filter, which is I think of it as good Maha and bad Maha. The bit of Maha that I find very attractive is the end chronic disease bit that says there's more to a health system than simply hospitals, which is what we were talking about earlier, that we really do need to look at the food system, smoking, activity, and also the role of government in actually making the country more unhealthy. I mean, we have chosen to have the junk food system we have. We have chosen to have the dirty air, the polluted rivers. These didn't happen accidentally. They were conscious regulatory and political choices. And what I find refreshing about the good bit of Maha is an honest discussion about those choices and a commitment to try to make them a little bit better. The bad Maha is obviously the kooky conspiracy theory, anti-science, anti-corporate, anti-vaccine bit of it, some of which is totally unevidenced. Some of it is mixed up with all sorts of distasteful American weird political traditions. And it's just a real shame that the two things seem to be almost intertwined and difficult to distinguish between the two. That's why I thought last week was so interesting, and the way it was being presented is there seems to have been, and I'd be interested in listeners' views on this, some kind of penny drop moment that the anti-vax stuff only gets you so far with a tiny minority of your voters. Now, they may be very activist, and it may give a neurological kind of surge to an unreachable group of people that is very useful for the strange Trump coalition. Okay, so I understand the pragmatic politics behind it, but it also severely damages your intellectual credibility. Poor old Trump, who did do well on Warp Speed, isn't allowed to talk about the COVID vaccine because he's Secretary of State, makes money suing companies about it. So that is an example of how awkward that agenda has become. On the other hand, some of the food stuff that RFK has been doing previously has been really a bit beside the point. Food dyes. Europe banned all those food dyes 30 or 40 years ago. So really, this is just America catching up with European food standards. Well, good luck to them, but it's not exactly revolutionary. But changing the food available by states in the food packages to poor people, that is a system change. That is a really emphatic. Not only does it change the procurement rules of government, it's a signal to industry. And I wish we would do something like that for schools and hospitals. I think that the British equivalent would be to take on board the Prue-Leith recommendations for NHS hospital food and the Dimbleby recommendations for school food. And I wish that we had a government that was gutsy enough to do that. There you go.
And true. The state approach to this, which of course is a very federal system in America, which it's not here at the moment, certainly not in health, and it's maybe going the other way, given that we're centralizing policy making into the DH, into the Department of Health. But of course, we do have these directly elected mayors, hopefully, coming online in the next few years during this Parliament, many of whom will have responsibility for health and care. Yep. Andy Burnham has it in Greater Manchester at the moment. So the new mayor that will be elected in Hampshire will have a deputy mayor for health and care, and they'll have those responsibilities. So they may have the ability to go there. I suppose what I'd just say finally on this is it's, with RFK, it's message versus messenger. So if you'd said many, many years ago that the earth is flat, but you then came up with a theory of relativity, does that undermine the latter because of what you've said on the former? I suppose RFK UK's Maha movement, it is focused on public health themes like sort of addressing chronic disease, nutrition, and environmental exposures. But I think it's also very politicized and controversial. And many people over there, and I, like you, have many friends over there, they see the real intentions behind some parts of this agenda. But others are concerned it sort of downplays the evidence-based prevention, especially vaccines, and then it leans in on non-scientific claims, and it's sort of part political strategy rather than it is a fully robust health reform program. It's a political strategy that Donald Trump thinks suits him. I'd love to know where soccer mom,
Yeah,
as used to be talked about in America, is on this, because obviously RFK had come out and said what he said about Tylenol, which is what they call paracetamol, and its use in pregnancy and then for its impact on autism. I mean, he's also said that there is a link between neonatal circumcision in America and autism, and that could also be linked to the use of paracetamol in pregnancy.
I know.
So when you say things like that, and we must come on and talk about that subject one day, as you know, but when you say things like that, then I suppose, do you undermine yourself as the messenger, no matter how good the message?
For sure. And listen, all of these criticisms are valid. And also, is this all just a massive distraction technique? Because actually, if you look at things like leaning in on weed killers, where America, performance of the agriculture in terms of poisoning their own people is terrible, they're not really moving the needle. So there is a lot of huffing and puffing about food dyes and not really any evidenced serious challenge to industry or public health discipline. I think it's a really puzzling mix. That I still come back a little bit to the rhetoric. It is very interesting rhetoric. And we were talking about your friend in Maidenhead who needed to find a new lexicon, a new political lexicon to talk about public health. Otherwise, he's just going to revert to campaigning for the local hospital. This is a group of people who have found a new lexicon, and I think it's worth us keeping an eye on it because they may be onto something.
Happy things as well for us to finish with, James.
Yeah.
Biobank unlocks GP records. The UK government this week has unlocked access to GP records for all 500,000 of UK biobank volunteers. So that doubles overnight the number of recorded cases for conditions like dementia, depression, asthma, eczema in the world's most important health research database. Now, you probably know a bit more about the UK Biobank than me. If you were jumping off the back of the bus and you had to describe what the UK Biobank is to our average listener, what is it in a sentence?
Well, it's an astonishing British national asset. It's led by a terrific British character called Professor Sir Rory Collins, and he's got 500,000 individuals in Britain who have got a lot of their blood, genetic, and personal data all in a bank over many, many years, which is a dream for doctors who are trying to understand disease, the causes of disease, the progress of disease. Very, very unusual. And it was always slightly flawed that the NHS kept people's personal clinical records fuzzy and hard to reach. So that if you had, say, Steve, if we had your bloods from when you were a teenager and we were trying to study the development of your disease, it would have been quite useful to also have your GP data as well. So being able to match that is going to be a big revolution. And genuinely, if you travel internationally, it's a well-known resource that people are extremely envious of. And so, yes, it's a bit like an upgrade to your Rolls Royce. It's very, very welcome indeed.
I was saying about the law lecture I was at last night, and the dinner I was sitting next to one of the law professors, and we were talking about the podcast, and she actually mentioned this story because it is quite niche, right? It's not retail front page of the Daily Mail's health pages, but she actually mentioned this story. And I suppose you've been involved in health data policy a long time and worked on it when you were a minister at the department. This whole care.data debacle, which very, very briefly, if you could unpack that, sort of killed public trust for a decade, didn't it? Does this sidestep the problem using the sort of consent model that Biobank have? Because I remember as a minister how much fuss there was around care.data.
Well, Steve, maybe you could just say a word about care.data because I have a completely different view on it than you do. But I know that you're going to articulate the consensus, and I have a disruptive view on this.
Well, I think the whole issue was around data linkage, the complexity of that, the whole issue around public nervousness around their data. Of course, it is all anonymized, but politics came into play as it always does, and the care.data backlash after the attempt, I suppose, national attempt to extract GP data for research back in so this care.data would have been 2013, 2016, so just before I was a minister. Yeah. It collapsed among media panic and public distrust, and policymakers were extremely cautious. And, number 10, this is not the only number 10 that at the sight of any caution panics and turns away and puts it back in the box. And that's really what happened here. But I suppose, we are quite a long way behind other parts of the UK on GP data for research. And actually, I think maybe things have moved on. Maybe people realise that it isn't just about how many more doctors and nurses you can employ. It's about whether you can use the amazing data that we have at our disposal in one of the world's biggest publicly funded health systems, and whether you can use the data revolution and the AI revolution to bring that to bear for all of our health and get upstream of these diseases by looking back at GP records and then using that to project forward. And I hope that we've moved past that in politics. But again, it would depend whether there's any more bravery in this number 10 than there is than the one that I had to work with. And I have to say, I think the jury is out on that right now, James.
So, Steve, you just articulated an explanation which I think a lot of people would recognise. I just very, very strongly disagree with it. I hope you won't. Your feelings won't be hurt.
Are we back to cycle helmets again?
yeah, and Cavaliers versus Roundheads. That's a conversation for another time. So this is so out of date, that the view you just articulated. I did a lot of work at this as a minister. We did a data saves lives piece of research, and what the British public really want is they want to be treated as an individual. People strongly believe that their health concerns are completely different to their wives, their brothers, their neighbours. They want to be seen as someone with very particular personal health makeup. And therefore, they want you to know all that you could possibly know about them. And they really don't like it if they have to repeat again and again and again the same basic stuff. So this idea that data is somehow frightening is not correct. In every other aspect of their life, from ordering Tesco on a club card to their banking to their telephone, there is a huge amount of data. Oh, and by the way, Facebook, my God, can you imagine how much data Facebook has on you? They're very used to lots of unknown people having a lot of their data. They obviously want it curated. And if it's health, it is more sensitive than perhaps their Strictly Dancing watching habits. But absolutely, it's not that they're frightened of people having data on them. They just want it to be secure and used properly. And in terms of research, my goodness, they want their data to be used for research. They're not frightened of that. They expect it to be done. There is no conversation about it. So when people say care.data blow up, the public, really? Or was it actually just a few clinicians, some of them quite ideological, some of them quite frightened of sharing their data because of legacy performance problems, some of them thinking that they might have something of value that they want to be rewarded for? Was this really just stirring on behalf of some people with an axe to grind? And where I would agree with you is that the politicians themselves have completely misread this one time and again. I kind of understand why people misread it 10 years ago. But on this side of COVID and AI and Facebook and the data explosion, I don't understand why we're still got our knickers in a twist on this one.
Okay. Well, maybe we're not in a cycle helmet situation. For those who didn't hear that episode, James and I have very different views on cycle helmets. I was wearing one on my line bike this week, which I know you would have been utterly disgusted by.
No,
but anyway, but look, I don't think I am out of date in my view on it. My reporting of the situation is that the technology was ready by the time I was a minister in 2017. That was not the main blocker. Politics was the major factor because there was a fear of repeating the care.data failure that paralysed ministers and paralysed number 10. And the institutional culture part of it compounded the political fear. And so the bottom line is that between those years that I was in office, 2017-19, England could have unlocked that GP
Yep.
records for biobank participants, and they could have done it technically, but political fear and bureaucratic caution,
Yeah.
that created a 3-year deadlock, which has left the country way behind Scotland and Wales. And, well done to Wes if it's his decision. Well done for Starmer for making one. Who knew that they've actually moved us forward this week?
I think the way you put it is very good. The bit that I push against is that the public are concerned about data. Honestly, I sat in focus groups and they're really not. It's not where the public are coming from at all.
No,
As you said, Steve, it is political hesitancy. And if I sound exercised about this, like you, I am frustrated that there has been a vacuum, essentially, with no leadership and no one out there saying, I share my data, I hope you will do too, because it's for my personal good and for the collective good. That message is not getting out there nearly enough, I think.
Few minutes, end on a something that actually works. £2.6 million, 20 new DEXA bone scanners across England. Over 16,000 extra scans delivered last year alone. So bone scanners that fight a silent killer. This sounds good.
It is. So frailty, broken bones, I mean, it costs us a fortune in terms of hospital admissions, in terms of either early deaths. If you have in fact, particularly women are hard hit by osteoporosis, but if you have an older relative, doesn't even have to be that old, much, 60s, 70s, who takes a tumble, slips on an icy path, they break their arm, it really hits their health very hard indeed. And the stats on it are very grim. If you're older and you have a serious fall, quite a large proportion, like half, are dead within a year, and it's really grim. So you can do stuff about it. If you have bones that are beginning to thin or get brittle, you can change your diet, you can do exercises, you can take hormones. There's a ton of stuff you can do. But you have to catch it early, like everything. It's like a common theme on this show. But how do you know? Well, you need a scanner, and they're not very expensive. We just need a few more of them. So I'm thrilled by this, and I honestly, it's a tiny amount of money in the scheme of things. 2.6 million. I bet this makes a massive difference. I hope that there's one in, I don't know, every single phone box in Britain.
Well, it's that awful stat, isn't it, about the number of cancers that are detected in the emergency department.
I know.
Wes Streeting was tweeting yesterday, for too many women, a broken bone is the moment they realised osteoporosis was already there, undetected, untreated. These new NHS scanners will help thousands of patients get tested sooner, start treatment earlier, and prevent painful, life-changing breaks. Absolutely. Well said, Secretary of State. The Royal Osteoporosis Society, we should say, they welcome the scanners, as you would imagine they would, but they immediately demanded a fracture liaison services plan, which is very, as you said, is classic charity move, isn't it? You take the win, but then you twist the arm for more, which I suppose
quite right.
That's what charities do.
That's what they're paid for.
So fair play to them. But we'll share the story on that one. I'll share the tweet from Wes Streeting on the social media channels of the podcast.
Can I make a small shout out for Guy Black, Lord Black, who has been asking questions about fracture liaison services for 5 years, almost every other week. Unbelievable stamina. And as you know, Steve, it's parliamentarians like that who help push on causes like this.
Yes, I know Lord Black is a good man. Yeah. Listen, that was a bumper episode. I don't know where time goes, but this has been Prevention is the New Cure. You can email us, actually, preventionisthenewcurepodcast@gmail.com. And you can also send us a WhatsApp. We'll give the number out again before we finish. You can find us on all our social media channels. And we just really want to hear from you, don't we, James? Because that gives us a chance to know what you're enjoying and what you're not enjoying, and, whether you like wearing cycle helmets or not. We're keen to hear.
And we're sometimes wrong.
Often wrong. Often
wrong.
I know. So that WhatsApp number again, 0333 404 6507. This has been the Health and Politics Podcast, Prevention is a New Cure, produced by Shortbread Media. We'll see you next week.